Welcome to the Equine Vet Connect Podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect Podcast. I'm Dan Carter. We're here at Countryside Equine Hospital. I've got Dr. Brown back with me today. We're in the studio, Old Treatment Room 1, and we're into part 2 of what I really think could be like a 12-week series.
Yeah, we could nerd out here for a while.
On ophthalmology. Yes, so just a quick recap. And if you're just tuning in this week, you need to go back and listen to last week. If you want to be a Countryside nerd, if you want to be an Equine Vet Connect nerd, you need to go back to last week. You need to go nerd out with us on how we got here, the anatomy, physiology of the eye. We did a brief rundown. We started talking about corneal ulcers, started basically getting into things we're looking at with an opto exam. So we're going to pick up again with corneal ulcers. We're going to keep our deep dive going. So let's start running through there.
Yeah.
So we're on the corneal ulcers. We've talked about the superficial ones. Talked about they get this small scratch in the eye. We talked about these are emergencies.
These are emergencies.
We need to get out there. We talked about we're going to be looking at things, doing an ophthalmic exam, signs to look for: excessive watering, we call epiphora. Squinting the eyes, called blepharospasm. We're going to go look at that. We're looking for that conjunctivitis. Once we see that, we're going to take out our ophthalmoscope. We're going to do a look over the eye. After that, we're going to do some fluorescein staining, shine a cobalt blue light on there, get some fluorescent green. We're going to find out it's there, and then we're going to start classifying it based on depth and size, right?
Right.
So let's get into let's keep rolling on these corneal ulcers. So let's start from there.
Yeah. So we have, kind of different classifications for things. The best way to break it down is, simple versus complicated ulcers. Right. So our simple ulcers are these more kind of shallow ulcers through kind of that top layer of epithelium. We haven't gone deep into that stromal kind of next layer of there. So we're shallow, and we don't have infection in there. Yep. So we've got something that we're like, all right, it's not, doesn't mean that it's not an emergency, but we've at least said, okay, we don't have a bunch of extenuating factors that have made this healing complicated. We need to follow a procedure, get it done, and, if everything goes correctly, should hopefully be out of the woods here in hopefully a couple of days. But as we start to get, some other factors in here, that's where we become more complicated. And complicated can come from a lot of other things. So depth is one of the things that makes it more complicated. Right. If we've kind of penetrated through that epithelium and we're now into the stroma, or all the way down through the stroma onto that kind of basement layer, what we call the Descemet's membrane, that makes an ulcer complicated just because, now we have a lot more layers that we have to try to heal. If we have some sort of infection in there, so we've been now inoculated with a bacteria or a fungi, which is going to be kind of common here in the southeast.
Yes.
We're going to be seeing a lot more fungal things. So that's going to be something, and one diagnostic that your veterinarian might do is a culture and a cytology of that ulcer. When we're dealing with these more kind of complex ulcers, so things that have been going on for a little while, or they're not healing exactly as they're supposed to, what your vet might do is they'll put a little block in the eye so that the surface is blocked, and then they will take a sample of the eye. A lot of times we'll use just the back of a scalpel blade to very, very gently just kind of scrape the little parts of the eye. It looks a little scary when you're doing it, but it's actually a pretty safe procedure.
Yes.
If the horse is, properly sedated and blocked, and you've got a good handler with you. So they'll take a little sample of that to look at what types of cells we have on the eye. It can tell us if we've got a lot of inflammation response, if we've got bacteria, if we've got fungi. And then they can use a culture of that to kind of get a better idea about what types of bacteria are in there and then what types of antibiotics they might be susceptible to.
So again, the depth is way more important than the actual size, because I've seen some of these superficial 1 to 2 layers thick. 3 days later, this ulcer is gone. Mm-hmm. I've seen some of these tiny pinpoint ulcers that are penetrating 6 to 7 layers, because you only got 8 to 12 layers, 8 to 12 cell layers thick before you start getting into the stroma.
Not a lot.
Not a lot, which is also why these are emergencies, because it doesn't take long for bacteria to eat through 8 to 12 cell layers thick. Mm-hmm. We're not talking huge here.
Right.
We're measuring in micrometers, not millimeters. So absolutely, like, getting there soon. People, I always say one of the most important things we'll do is that cytology, and something as simple as a gram stain. Mm-hmm. So if you're dealing with a gram positive or gram negative, it really helps us make a decision then while we're waiting on that culture.
Right.
I'm a big gram stain guy. Mm-hmm. So yes, absolutely. Let's get that culture and sensitivity going. Let's do that debridement, and that's the other thing people don't think about. Sometimes you've got to debride the cornea.
Oh yeah. I've had some ulcers that I have been just fighting with, and I'm like, all right, we don't have an infection. We're not super deep. Why are we not healing?
Right.
And then I've gone in and looked at it, and there's a lot of just kind of dead shmoo just sitting on the cornea. Mm-hmm. And we take it and we just kind of freshen up those edges. Ulcer's gone in like 2 days.
Again,
I'm like, what the heck?
Just like skin, though.
What the heck? Yes.
It's epithelium. It's just like skin. You've got that wound that we're dealing with on skin. Mm-hmm. It's not wanting to heal. We've got to get infection under control. Sometimes we've got to debride that wound. Mm-hmm. And once we do that, we get it to heal. Yeah. Eye is no different.
Yes.
It's no different.
No different. It's crazy. And the eye is, if there's no extraneous factors that are preventing us from healing, the eye is really good at healing itself.
Yes.
It is really, really good at healing itself. And so how the eye actually heals is kind of interesting too, because you have to think about how these different layers actually work. So the epithelium kind of works by just kind of creeping back across the surface itself. Mm-hmm. So it travels something like, a couple millimeters a day.
Yeah, I think 1 to 2 millimeters.
1 to 2 millimeters a day or something like that. Like in the whole, kind of diameter of your average horse eye is going to be about, like 30 millimeters across. Mm-hmm. So if you think about, big ulcer that's taking up the whole space, if you've got, good response coming across, if it should be taken about, a week for a whole massive ulcer that's taking up the whole eye to heal. So that kind of gives us a little bit of, at least a timeline of like what we're expecting for healing. Mm-hmm. So you start to see this epithelium kind of coming across and healing itself. But you run into problems when these ulcers are now penetrating into the stroma, because the stroma is more of a collagen based. So it doesn't really heal the same way as coming across. It kind of has to more fill itself in. And in order to do this, you have to have these vessels kind of penetrate from the outside of the eye and go kind of track deeper. And they don't really do that very well. The eye it's vascular, but it doesn't really want the cornea to be super vascular itself.
Right. Well,
so it just makes it a little bit harder. And what we run into is these kind of deeper ulcers. If we're not taking care of the infection right away, that epithelium will go ahead and heal itself over, but it's leaving this infection underneath.
Leaving that void. It
leaves a void, and with that void creates every vet's worst nightmare, the stromal abscess.
Yes. A way to think about it, I think most people that have had horses have had a tendon or a ligament injury. Mm-hmm. And so tendons and ligaments, they're made of collagen as well. Mm-hmm. You're going to hear us talk a lot on this podcast about collagen. Collagen in my world, or just the way I look at it, collagen is truly what holds the body together. Mm-hmm. We don't ever talk much about collagen, but it is the connective tissue that literally holds the body together. The eye is no different. And if you've had a tendon or ligament injury, you've probably heard these take a long time to heal because we don't have great circulation.
Right.
It's the same thing with the stroma. We don't have great circulation in there. We've got to get those blood vessels there. We've got to get that stroma to heal. And during that time, we're just trying to keep infection at bay so that the eye can heal. We don't heal the eye heals itself. We just provide the optimal environment for the eye to be able to heal itself.
Exactly. So when you run into these more kind of stromal abscesses, you're kind of buying yourself a lot more treatment time for them because now we've got this deeper seated infection, and the eye is not happy about having all that in there. We've kind of created this kind of perfect storm, so we're going to be really, really kind of fighting with these things. And so probably with getting your vet out there, yes, super important, but also getting really aggressive.
Yes.
Really early on. If you've ever seen me for an ulcer, you probably can attest that I like to scare people a little bit when it comes to ulcers.
I like to say this is definitely a time you want to kill a mosquito with a sledgehammer.
Yes.
You don't want to mess around here.
I've just seen too many ulcers go from bad to worse in such a short amount of time, and even with us getting there quickly and trying to do the right things. So when I get to these ulcers, I'm like, even if it is something kind of small or simple, not really super ugly at this point, I'm still gonna throw everything I've got at it, and I like to follow up with them relatively quickly. I like to check in usually within about 48 hours of me first kind of looking at it, just so that we can make sure that we're on the right path. Because if we're getting 48 hours out of treatment and we're not on the right path, we need to fix something. We need to either do some more diagnostics, we need to change our treatment plan, we need to do something else, because if we fall too far behind on these things, we can be in a pretty bad spot.
Well, and the other place that we talk about these penetrating wounds to the eye, again, we talk about this time of year, we're going in, it's mid-October here, we're going to have more and more feeding of hay as our grass starts to go away. And that's a common spot as well, where these horses actually get a something that actually penetrates through the cornea, doesn't necessarily leave an ulcer, but it pops through those initial layers, seeds bacteria in that deeper stromal layer. And again, we set up with stromal abscess. So we may not see an ulcer that first visit, but the eye's not getting better. Like if we're 48 hours in, we didn't see an ulcer, we started on some meds, but we're not getting better, we're going to do that recheck. And then unfortunately, we may see that stromal abscess from that penetrating wound to the cornea.
Yeah.
And that's, again, stromal abscess is...
Nobody wants to see one. It's no vet is excited about a stromal abscess. No. So let's kind of start talking about what treatments are we going to be expecting when we diagnose one. So first thing we're going to be kind of addressing is our antimicrobials.
Right.
And so even if we don't have an infected ulcer, those antimicrobials are going to be important because we want to prevent that ulcer from getting infected. So we're going to want to use something, if we're not doing a culture, if we're just kind of, treating to treat, we want to do something that's broad spectrum, that's going to cover lots of different types of bacteria. So probably our most common thing that we use is triple antibiotic or neopolybacterin.
Yep.
This is different from the triple antibiotic ointment that you can buy at a store for skin wounds. They are different. The same thing. You cannot put regular triple antibiotic ointment into an eye. It has to be ophthalmic.
And I want to stop here and make this clarity too. There's different forms of triple. We have neopolybacitracin. We also have neopolydex. It has dexamethasone. There's also one with hydrocortisone. I cannot say this enough. Just because you have an eye med, don't say, hey, I'm going to start treating this myself. Because if you have one of these that has dexamethasone or hydrocortisone in there, this is you can really cause an issue. This is a big deal.
And it's interesting too, because when they treat humans for corneal ulcers, they will put you on a steroid.
Yes, they absolutely will.
It just scared the living crap out of me when I went for mine. I had a corneal ulcer, and they put me on a steroid, and I freaked out. And they're like, "Yeah, but you're not a horse."
That's the same thing. I started freaking out when I had mine.
I freaked out. I was like, oh.
So again, I call it Steinbeckian because old John Steinbeck wrote the book of Mice and Men. And I can tell you Steinbeckian biology and Steinbeckian medicine does not apply to horses.
No, it does not.
They're kind of an island unto themselves. So just because it's done in human med or on your dog, it's not the same here.
Right.
So absolutely, that antimicrobial neopolybacitracin, use our first line of defense. That comes in multiple different forms. Sometimes it's a liquid. Sometimes we're going to use an ointment. I'll be honest, I think the majority of times it depends on what the manufacturers are making, because we always fight this on iMeds. It seems like they're always disappearing.
Yes.
They're constantly going on back order.
Yes.
So, but the neopolybacitracin, absolutely, it's a great first line of defense.
It is a great first line of defense. It's definitely something, if you have your own kind of at-home first aid kit for your horse, that should be something that's in there.
Yep.
A lot of times if I get a phone call from a client and they say, "Hey, I've got, my horse is squinting and, I want you to come out." If I can't get there, right away, and if they have, the ophthalmic triple antibiotic ointment, I will say, "Hey, go ahead and just put a dose in there."
I mean, we're starting then. Like, we may be there in 5 or 6 hours, but that's how big of a deal it is. Like, go ahead and get that first layer of antibiotic in there. We're going to be there in a few hours.
Right.
But let's go ahead and start.
Let's go ahead and start. Exactly.
But again, not the one with dexamethasone.
Not the one with dexamethasone.
Or hydrocortisone.
And the reason for that is because the steroid, it does a couple things. It kind of, suppresses that immune response that the eye needs to try to fight the infection. And, again, because we don't always know right away if there is an infection in there. And so if we have a bunch of bacteria or fungi or something in the eye, then that steroid is going to, kind of stop the eye from being able to fight that and kill that.
Right.
And so we don't want to take that risk.
Absolutely.
And I've seen what an infected ulcer looks like in the presence of a steroid, and it is not fun. You do not want to take that risk. You go from bad to worse really quickly.
Couple other antibiotics we might use.
Ofloxacin, that's another one that we use. It's just got a different, spectrum of that. So kind of depending on what we see in that culture. Tobramycin's another one, chloramphenicol, gentamicin, just to name a couple different types of antibiotics that, your vet might use.
Yeah.
And then in that kind of realm of antimicrobials are our antifungals. So something really fun about the Southeast is that we have no shortage of fungi here.
It's interesting when you talk to vets from California and the Northeast. They never deal with these fungal infections.
No.
And down here, we live with fungus.
Yes, everywhere.
I mean, it's really and truly, I think if you've got, like, if I look at an ulcer and it's going to be more than, if I think it's going to take more than 2 or 3 days, if it's more than a tiny superficial, I'm grabbing an antifungal.
And I always put mine on an antifungal.
Right.
I got my education in Florida, and so if there's a lot of fungus here, there's way more in Florida.
Yeah, I got mine in Georgia, and it's the same thing. A lot of fungus here, but Florida, you just accept, like, if you have a corneal ulcer, it's got a fungal
until proven otherwise.
Yes.
And even then, even if you do a cytology and I don't see a fungus on it, I'm still like, I don't care. You're getting an antifungal.
And the downside is we used to have several antifungals. Miconazole was one, itraconazole was one, voriconazole is kind of our big gun. And what we've seen recently as we're surveying these different funguses that are out there is we're seeing very little sensitivity to itraconazole and miconazole. We're kind of in voriconazole land.
Yeah.
I mean, that's one of the ones we grab right away.
And fungi are They're a very unique, just kind of organism to begin with, because they don't really respond well to a lot of treatment as it is. They have a very unique just way of processing these antifungals that we give them, and they take a really long time to be killed too. Like, I mean, a lot of times when we are dealing with a true fungal infection, I mean, we can be treating these things for months.
Yes.
And I've even had some, fungal ulcers and abscesses that end up having to go on a systemic antifungal as well, just because the topical just sometimes just isn't enough to treat it. And so even though the eye kind of has poor systemic circulation, things don't really penetrate it well, sometimes just, anything else we can get ends up being enough. So any fans of The Last of Us is actually probably one of my, scariest shows I've seen, because it is like fungal zombies, and I'm like, yeah, that's something that could like actually happen. Fungi terrify me. Like,
and they should.
They are no joke.
They should. And unfortunately, we've got a long list of antibacterials, but we've got a fairly short list of antifungals.
Yeah.
And fungals can develop resistance really, really easy.
Yes.
And like I said, fungus. Luckily, we kind of keep records here of what's working where, and we also have the other thing that's important to know if you're in the southeast is fungals are inhabitants of the environment. So if you've had one of the things we look at, if we've had a fungal infection at a barn, we keep a record of that, and we know that if we see a corneal ulcer there, we've had history of fungus. That horse also goes on an antifungal right away. Because we know it's in the environment. We know this can cause an issue. Again, we're getting aggressive. We're killing mosquitoes with sledgehammers here. We're getting this antifungal in the eye.
Absolutely. And again, there's a couple different ways for us to deliver these medications to the eye. So ointments are available in a lot of our treatments, and so and a lot of people can get the ointment in there. Horses are, a lot of them are tolerant of it. Some of them aren't so much, especially if you end up treating them for more than a couple days at a time. They can start to get a little resistant to it. And some of these more, serious infected ulcers too, treating 2-3 times a day just isn't going to cut it. We need to go a little bit more frequently. So,
let's talk a little bit about that, because when we talked about it in the last episode, we talked about tear film. Tear film is both aqueous and also has a mucus layer. If we're dealing with infections, we know that mucus layer, one of the things that can happen is that mucus layer gets diluted out. We have more of the water or the aqueous portion.
Right.
And that's why these meds can wash out of the eye quite quickly.
Exactly.
I tell everybody, when you have a corneal ulcer, you're going to get to know your horse really well.
Really, really well.
Because unfortunately, you're going to see them a lot, because these eye meds are going to have to be put in quite frequently.
Yes. So, one of those, kind of solutions we have to that is a system called a subpalpebral lavage, or SPL. So basically what this is it's a teeny tiny little catheter that we place kind of under their eyelid, and it goes up through their eye and then snakes kind of up their head, and we usually secure it down kind of at the base of their neck. And it's basically a little tiny catheter that we can push all of the liquid meds through, and it goes directly into their eye. So that way we're not sitting there having to repeatedly, push their eye open and smear all of the ointments in. It kind of confirms that we are getting these meds to their eye, and we can do it every hour. We have a lot of these eyes that we are, if you look at it, like some of these, if I make a little chart, we're treating these eyes 100 times a day.
That's what it feels like.
It is.
In that SPL, I can tell you it's a definite game changer. My big rule is, like, if we're going to get more than a week, like really 5 to 7 days.
That's about my cutoff too.
I'm going to talk to you about an SPL. And I can tell you, I've never put an SPL. Somebody did not thank me for putting in an SPL. And if you've ever dealt with a corneal ulcer, it's interesting because if people have had an SPL before, their first thought is like, can I go ahead and just get that SPL?
Yeah.
Because it does make life a whole lot easier.
And it's also kind of, based on the horse too. And everybody knows their horse that just hates having their face messed with
Right.
at all. So we have some of these horses, if we know that we're going to be, doing this for more than a couple of days, it's like, hey, let's just go ahead and put it in there.
Yep.
And with that too, comes with one of the issues I see with ulcer healing is self-trauma of the horse, because these things are painful and they can be really itchy. So horses will sit there and they'll try to scratch their eye themselves.
Right.
And so protecting the eye while you're doing treatment is super important. So for a lot of people, a fly mask works fine, because it just kind of gives a little cover over the eye. But, what I end up doing with a lot of horses, and especially the ones that have SPLs in them, is we do a little mask called a bubble mask.
Right.
And it's just a big kind of plastic cup that goes over their head. They can see through it. In the ones that we use, at least they're clear and they're plastic. And it just, kind of gives that extra layer of protection so the horse can't sit there and rub it. And it just protects everything there.
A lot of great options out there too, because before all we had was like this one cup.
I hate the cup.
Set over the eye.
I hate the
and
cup.
now with I think they call it Equivisors.
Equivisor, yes.
I tell people, if you don't own an Equivisor, you probably should, because it does help protect that eye. It does a fantastic job. They can see through it. The horses are not going crazy. You can actually get them tinted. One of the things we're going to talk about is atropine.
Yes.
Or actually, we talked about that earlier in the last episode, was using atropine to help out with the pain, but that also dilates the eye.
Yes.
If you've ever been to the eye doctor yourself and they've dilated your eyes, they tell you to make sure you've got sunglasses, because when you walk outside, your pupil can't get smaller. That iris can't constrict. And that light's really blinding. And so some of the tinted Equivisors have really helped with
It does, yes. Or you can buy, like a shade that kind of goes over
Right.
it too. Like I've seen like kind of a tinted fly mask. So, if your horse is, going outside for part of it, they can. So have a little extra
protect that
protection. But yeah, I've had a lot of horses that I've been like, why aren't you healing correctly? And then, put a bubble mask on them and then night
Bam.
and day. And we have them here for rental as well. So, if you don't want to purchase one for yourself, just talk to us when we're treating your horse, and we are more than happy to rent you a bubble mask. And we'll save you a lot of money on the back end with us having to come back out and treat them again and again and again, because they just keep tearing it open.
And I tell you, we're most clinics have got them to rent. You just get one of these from the get-go. It really makes a big difference.
Yes, absolutely. Absolutely.
So we've talked a little bit about the antimicrobials, antibacterials, antifungals. We're going to figure out the best one to go with. Going to set you up on a rate. Atropine we touched on briefly. Atropine is going to help prevent that synechia. It's also going to help out with pain.
Pain, yes. Pain is really interesting in horses too, because they, like we kind of talked about in the last episode, horses are really tolerant of pain to a certain point. So, and these ulcers are super uncomfortable.
Yes.
And so, we want to try to provide as much relief. So the atropine is going to do that, but systemic NSAIDs are going to be, just as important for it as well. So Banamine is your friend when it comes to this.
Definitely.
It does a really good job of just kind of controlling that inflammation in the eye and doing that. And, and we very regularly put these horses on Banamine while they're on it. I've seen this whole thing with, they're like, oh, well, Banamine it's not good for the horses. It's, it can cause stomach ulcers. It can cause, colitis. It can cause kidney problems. But what also causes the gut to slow down is pain.
Yep.
Pain.
And there's a lot of things we can help with if we're worried. Like if we know we're going to be on long-term Banamine for the eyes, we're going to get them on Gastrogard.
Yeah.
Help out with that stomach. We'll keep an eye on blood work. We're going to make sure those kidneys are doing what they should do. And again, use the NSAIDs. Banamine, just no Banamine. No Equiox, no Bute. Banamine's where we want to be.
Banamine.
Some of the other treatments, let's talk about. I'm a big plasma guy.
Yes.
Love plasma.
Love some plasma.
So we're able to. You're gonna see us pull blood from your horse. We're gonna spin it down. We're gonna set you up with some plasma. That's the liquid portion of blood. We talk about serum. We talk about plasma, but I think we're using more plasma now than serum.
Yeah, I think it's when we talked about it this weekend, they said it's really kind of clinician preference.
Right.
Serum is probably the easiest to make because it's we can pull it right off of your horse and we just spin it down and pull it off and give it to you, and it's good to go. So if we do end up doing this, the purpose of it is it's going to help with that kind of collagen breakdown. So what we talked about in the last episode with kind of these melting ulcers, where we've got these, kind of enzymes that are just breaking down all of the tissue on there. The plasma or the serum is going to help with stopping that process.
Yes.
So that's kind of the purpose of that. And I actually talked to a lot of vets over the weekend about this, that they put kind of all of their ulcers on it, even just their really simple kind of quick 2-3 day ulcers. They'll put it on there just kind of help with speeding the healing process along. And it's organic. It comes directly from your horse. And, we can, just kind of safety with it. When we do pull it off, we'll give you some to start off with. We usually do it a couple times a day. You can use that for up to a week.
Right.
And then you need to throw it out. But usually when we take enough, we will freeze any excess that we have, and we can go ahead and give you some more, and you can keep the rest in the freezer, and it's good for up to a year in the freezer. But it's, we make a ton of it at a time. It's not really a super big process. As long as you've got a centrifuge, you can make it happen.
And I think that's important to remember when you get that plasma, put a date on there.
Yes.
And when you get to the 7-day mark, trash it.
Trash it.
Just trash it. Get some more, because it will grow stuff.
It will.
Keep it in the refrigerator. Clean needles. I cannot stress this enough, because we're dealing with SPLs, or we're dealing with liquid meds. You're going to get a box of these little TB syringes, these small syringes. They're single use.
They are.
Single use, because you don't want to have a contaminated syringe. I've seen that happen before. People are trying to save syringes. You feel like you're wasting, but then that syringe becomes contaminated. So every time you're putting that med in, you're putting bacteria back in the eye. So again, you're going to get a box. Your vet's going to give you a box. We're not going to reuse these things. We're going to trash them.
Right. And kind of going into that too, I think talking about just like expectations of treatment, especially for, these more kind of complicated infected ulcers where, all right, now we've got an SPL. We're on meds, every 2 hours. And this can go on for a long time. Some of these really deep infected, like fungal abscesses, we're going to be treating for weeks, sometimes even months.
Right.
So, I think really, and kind of important on our end is just getting that communication across and saying, hey, this is what this is going to look like. So, and I think it's important to work with our clients and saying, hey, let's make a schedule so that, we have a daily schedule if we're at home, making sure we're getting treated. Put a team together if you're at a boarding barn or you've got family members that can help you out, doing night meds and stuff. That's going to be, really, really helpful to, kind of check off little boxes and make sure that meds are getting done when they're supposed to, and that everybody kind of knows what to watch for and, what the expectation is. When I was on my equestrian team in college, we had a horse with an SPL, and we really liked this horse. So everybody on the team kind of got together, and I was doing meds at 4 a.m. So, but that was kind of part of it, and we had to kind of just work together to make sure that this horse was getting what she needed, and it ended up working out. But
I think the other part of that is, we're talking about these eyes, and we're talking about, it may start out superficial. It can change rapidly.
It can.
And so we're going to be examining. Your vet's going to want to examine those horses quite frequently. So when we talk about, hey, we're going to be back in 48 hours, that's not like, hey, the eye's doing better, can we push that? No, we're coming back in 48 hours. Sometimes I've had some I looked at and said, hey, we're coming back tomorrow, because we may have some concerns with something we're seeing in the eye, and we want to make sure that eye's getting on the right track. We may check them in 24 hours.
Right.
And so you're going to have these frequent rechecks. Just know that up front. We're going to have these frequent rechecks on these eyes.
Yes.
Because things can change, and with that, we may need to change medications. We need to change techniques. This is something that we're watching very, very closely.
And, and one thing that I don't want to rule out is surgical intervention.
Right.
Especially on these very deep, very infected ulcers. If surgery is an option for your horse on these deep ones, I think it's a good, path to take.
Correct.
Because, and we would refer this to, you know, a boarded ophthalmologist at this point, because, you know, they can do a lot of different things. There's a couple different procedures they'll do. They can actually kind of cut these abscesses directly out of the eye, and then they will do a corneal graft to just replace that cornea. They can also do something called a conjunctival flap, where they will take a piece of the conjunctiva, which is the mucous membrane of the eye, and kind of bring it down over that lesion and allow it to try to heal, just bringing some more kind of blood vessels and, you know, immune response to that portion of the eye. And, you know, for a lot of these horses that have these really deep, nasty lesions that we're like, you know, it's going to be a long process. If we can go ahead and do the surgery, we can get it taken care of right away.
Right.
And, you know, we're not totally out of the woods yet. We're still going to be, you know, treating the eye at that point, you know, and trying to make sure that everything's healing correctly, you know, trying to prevent any further infection. But, you know, if that is an option, I think it's good to, you know, get that communicated early on so that we don't get to, you know, several weeks, months of treatment. And, you know, cost is a big thing with these as well. It's not uncommon that, you know, we're talking thousands of dollars in treatment
I would say
at the end of this.
People always talk about insurance on their horse because of colic. No. Insurance is for eyes.
It is.
Because it's like the slow drain.
It is. It is. And I think, you know, just knowing early on that, you know, could be a really long process. This could get expensive. This can get frustrating. You know, we're going to have really good days, and then we're going to plateau a little bit, and we need to change our plan. And
mutual fund analogy, right?
Yeah.
You're going to have good days and bad days. It's that trend over time.
Right. And you know, and it's, and something too that I do leave, you know, open is that we may not win. You know, we may be treating this for months, and you know, we run out of money, or, you know, the eye still ends up rupturing, or, you know, sometimes if we can't get the inflammation under control, which we'll talk about, you know, kind of a little bit later, one of the, you know, kind of consequences of long-term consistent inflammation in the eye is retinal detachment and degeneration, and so we lose vision in the eye. And if that happens, you know, sometimes we say, hey, let's talk about enucleation.
Right.
And so enucleation is the surgery where we remove the eye. And, you know, and it's a big step for a lot of people. One of the ophthalmologists I worked with, they said, you know, this was in reference to dog owners, but they said, oh yeah, owners will cut off a leg, no problem. But you talk about taking out an eye, and it's a big deal.
I agree. But it is, you know, in some of these situations, it's the best thing.
It is. Especially
these eyes are chronically painful.
Yes.
This changes horses' behavior. It changes their mentality. I've learned over the years, horses' acute pain, they'll deal with.
Yeah.
Chronic pain, they struggle with. I've had some of these horses that really struggling to work. They didn't want to work. They were just not fun to be around. 24 hours with the eye gone, and they're happy. Yes. They're happy.
And they do remarkably well. I mean, horses can have a athletic career with one eye.
They do incredibly well.
I learned how to jump on a little one-eyed pony.
Yes. I think everybody that's been in horses has seen that. That one-eyed pony. It does great.
Yeah, they do fantastic. You know, it's definitely an adjustment for horses that do, you know, lose that eye. You know, they can be a little spooky on that side. But horses do really well with just kind of consistency in their environment. So, you know, if you keep them, you know, in a pasture, and as long as you're not planting new trees or doing too much, they tend to do well. A lot of times they'll actually use their pasture mates as kind of a buddy, and you'll a lot of times see the pasture mate kind of standing on that side that doesn't have an eye, just to kind of give them a buffer. I always find that interesting. I'm like, there's that herd dynamic.
Yeah, they take care of each other.
They do. So, you know, horses can do really, really well, and so I think it's always, you know, it's important that we kind of communicate that early on, that, you know, if we're like, hey, this is going to be a really, you know, kind of long process, and if it's just not something, you know, that the owner or, you know, the barn manager is able to do long term, or, you know, we have some financial constrictions, or, you know, the horse has, some sort of, systemic issue that's going to prevent it from healing really well. Like Cushing's disease is probably our most common thing that we see that, just as a systemic issue, the body is already not really great at, dealing with any sort of infection. So,
and that's a really good point. If we've got an older horse and this ulcer's not healing, we may have no other signs that Cushing's is a factor. Other than we're treating this ulcer aggressively, it's not wanting to heal. Yep, you're fixing to get tested.
Yeah,
you're getting tested.
And right, so if we've got all these kind of extraneous factors that it don't make it a good candidate for long-term treatment, enucleation I think is sometimes a very viable option.
Well, and another thing, I'm not sure if they covered this down, but did y'all talk about subconjunctival injections?
We did.
It's it's another great technique that I've used, especially with fungal keratitis when I'm dealing with these fungal infections. If you can we talked earlier in the last episode about blood vessels migrating to the site of the ulcer, because that's one of the things the body will do. Is it'll start to push blood vessels from the more outside areas of the eye. It'll start moving these blood vessels into where that ulcer is. It'll grow about 1 millimeter a day. When they get there, it opens up a whole nother range of treatment.
Yes.
Because we can get in these subconjunctival injections, tiny little bleb underneath the skin, and a lot of times we'll do it in the upper eyelid. We'll actually put a medication in there. Crazy enough, it will somehow migrate into that blood vessel that's in the eye, and it will deliver that medication to the area.
Yes.
I've had a lot of, especially when I'm dealing with fungal infections, I've had a lot of great success using amphotericin B subconjunctivally every other day, and had really good results. I've actually done a few other medications as well. I've done Maxtel in there, gentamicin. Great technique.
One of the ophthalmologists I was working with, they said, anytime they put an SPL in, they will immediately do a couple subconj injections of all of the liquid medications and just go ahead and just put them in there. Great technique.
So that's some other things you may hear your vet talk about when we're treating these corneal ulcers. You hear about topical medications. You hear about subconjunctival injections. Don't be afraid of these things. Right. They're very, very, very effective.
Exactly. So, and I think just kind of, wrapping up, ulcers in general, I think, our kind of key takeaways are get help early. Early
aggressive therapy. Aggressive therapy. If you learn nothing else, there's two things I would love people to take away. If you have an ophthalmic issue, call the vet. Number two, go ahead and when they start talking about early aggressive intervention, shake your head yes. You want to start early. You want to be aggressive.
Yes. I as a vet will never be upset if somebody calls me after hours about an eye. No. I will never, be like, ugh, that's like, get it together. No, I'm like, no, this is something that we need to deal with.
Yep, it's like, I just need your address and I'm on the way.
Yep. Or if it's the middle of the night, I'll be like, I will see you at 8 a.m. So.
Right. We're going to be there.
We're going to be there as quickly as possible.
Within hours.
Yes. Getting these seen early on, I think is really a lot of times it is the difference between, getting something quick and dealing with it in a couple days versus, being months in. And
because as you've heard throughout this podcast, there's a lot of options, but timing is everything on whether we have these options or not.
Yes.
So aggressive therapy gives us more options. Early intervention, more options.
Right.
The other one, patience.
Patience.
These, I tell people, there's two ways you can measure time: stopwatches and calendars. Eyes fall into the calendar world. You've got to be patient. And interesting enough, like I've seen some eyes that were nasty fungal infections. The eyes completely clouded over. You think there is no way that this horse is ever going to see through it. Give them time. Now, we're talking years, but I've seen these corneas clear up. And one of the things that I remember Dr. Brooks saying down at UF was if they have a dazzle, which is where you shine, if you can shine a bright light in the eye, see that pupil constrict, you have a chance.
Yes.
And so, yes, the eye may not look good, but be patient. Even once we've got this ulcer cleared up, you're not happy with how the cornea looks. Give it time. The cornea has an amazing ability to remodel itself. It takes time.
It does.
But it can happen. So patience. Lots of patience. And just, communication right off the bat is super important between, the vet and the owner or the people that are going to be treating the horse. Right.
You just, knowing what the expectations are and, what we have to do, I think is really important. And just, be honest with your veterinarian. If they're telling you something and you're like, I don't know if I can do this.
Right.
Talk about that early on, because, that's something that we need to know early on, and so we can kind of talk about other options. So
I think a big one is if you know this horse is more head shy, it's going to be a struggle to get those meds in. Maybe we don't wait on that SPL. Maybe we get that SPL in there day one.
Yeah.
If you're like, I don't know that I can get the medication in, fantastic.
SPL. Right.
Also communicate. We may do a recheck and say, hey, it's going to be, we don't need to see this eye's in great shape. Let's don't look at it for 3 to 5 days. But if you're looking at the eye and like, this thing looks like it's getting worse, call.
Let us know.
Don't wait for that recheck. Go ahead and make the phone call. One of the great things is the cell phone.
Yes.
Pictures.
If
you're concerned, shoot your vet a picture. Like, hey, I'm not sure if this looks okay. But don't wait just because we said we don't need to see this eye for 5 days. Don't wait for 5 days. If you're not happy with how something looks, make that call, communicate early. We don't want to get there and say, well, it started looking worse 3 days ago. No. Communicate early. Communicate early.
Absolutely. And, have a team together. If you're going to be on meds, multiple times a day, and I know most of us have a day job and families and things. So, if you've got, people that can help you out and be doing meds, throughout the day, it's just going to make it, that much better of an experience for everybody.
And sometimes it's okay to say, hey, maybe he needs to come to the clinic.
Yeah.
We've got people.
We do it here. We've had horses that here with SPLs in that, we all kind of work together and make sure that everything gets done, and we can kind of keep an eye on it there too. So. And
the next one I always talk about is expectations.
Yes.
Just know we can do everything perfect. You as the owner can do everything perfect. An ophthalmologist can do everything perfect, and sometimes we still lose.
Yeah.
Sometimes we still lose the eye. But if we do, it's not the end of the world.
It's not the end of the world. It happens, and it stinks. Nobody wants it to happen.
No.
But it is a possibility. Even like you said, we do everything correct, and it still happens. But it's not a failure. Horses can go on, and they can still live a very happy life with one eye. So
yes. So summing everything up, keys to remember: early aggressive therapy, be patient, communication, and expectations.
Yep.
So, all right, another great episode. Thanks everybody for tuning in to the Equine Vet Connect here at Countryside Equine Hospital. We're going to do some more topics on eyes. We've just, terrible pun here, we've just barely scratched the surface of ophthalmology. Yeah, dad joke. So, I got 2 kids, so I can do that now. Dad joke. Yeah, we're going to be doing some more topics on ophthalmology. If there's anything y'all want to learn, we've been getting some great suggestions. Send us a DM, send us an email, shoot us a text, give us a phone call. If you really want to be old school, put a letter in the mail. Everybody loves to get a letter. So however you want to communicate with us, send us some information. Be happy to cover that topic. Thanks for tuning in. Dr. Brown, thanks for being here today.
Yeah.
And thanks to the team for making this successful. And we will see y'all next week. Thanks.
Bye.